We can start.
A very good evening and warm welcome to iFocus Online Lecture 518, the ninth in the series of eye and systemic diseases. Today we have Dr. Padmamalini Mahendradas from Narayana Nethralaya, Bengaluru to teach us about eye in systemic viral infections. She's done her MBBS from Stanley Medical College, Chennai, her DO from Regional Institute of Ophthalmology and Government Ophthalmic Hospital, Chennai, her DNB from Prabha Eye Clinic and Research Center, Bangalore. She's currently the head of uveitis and ocular immunology services at Narayana Nethralaya, Bengaluru. She's the vice president of Uveitis Society of India and Society of Inflammation Research. She's received 21 awards, including the recent APO Achievement Award in 2025. She's also included in the proud Stanford's list of top 2% researchers in the world in ophthalmology for 2023. She has over 204 index publications, 42 non-index publications, 41 book chapters, and she's also the reviewing editor for ocular immunology and inflammations and in the frontiers in ophthalmology. She's a member of the International Uveitis Study Group and the International Ocular Inflammation Society. She's a proud invited speaker at several national and international conferences. We're glad to have you, ma'am. Over to you.
Thank you for the kind introduction. Very good evening to all of you. Just a minute.
Yeah, it's okay, ma'am.
Is
Yes.
it visible?
Yes, ma'am, it's visible.
Yes. At the outset, I would like to thank Dr. Santosh Unavar and Dr. Partho for inviting me here today to speak on eye and systemic viral infections. I do not have any financial disclosures. The next 15 minutes also, I'll be talking to you about various systemic viral infections with eye manifestations, the commonest being the human herpes virus and human immunodeficiency virus. Human immunodeficiency virus, we have a separate talk by the subsequent speaker. The next comes the measles, mumps, and rubella viruses. And then arboviruses. In this, we have dengue, chikungunya, Rift Valley virus, and West Nile viruses. The next comes influenza, Ebola, and Zika virus. Recently, SARS-CoV-2 have been added in the list. Viral conjunctivitis is the commonest manifestations, is commonest, highly infectious. Most of the times it is self-limiting. Sometimes it can have prolonged course with membrane formation and also subepithelial scarring. In conjunctiva, acute follicular conjunctivitis is the commonest presentation. It can have associated respiratory and other systemic flu-like symptoms, can have watering, grittiness, watering in the eye, conjunctival hemorrhage, and sometimes corneal changes, can have associated preauricular lymphadenopathy. Most of the times it is associated with the adenovirus serotypes 1 to 4, and we manage this patient symptomatically. Next, we move on to herpes virus. When we look at this, they have various systemic manifestations. This is herpes simplex case, and here is a case of a herpes zoster. When we look at these features, we know the systemic diagnosis is most obvious. Coming to the ocular features, they can have scleritis, they can have uveitis, can have keratitis, and have atrophic patches on the iris or neuroophthalmic manifestations like third nerve palsy. In this case, is a case of herpes zoster, or can have neuropathic keratopathy. Coming to herpes and ocular surface, it affects the ocular surface. Because of the direct viral replication, we can have dendritic or geographic epithelial keratitis, sometimes ulceration. Coming to host immune response, it causes stomal keratitis, keratoendothelitis, keratouveitis. If there is a direct nerve damage, can lead to neurotropic keratopathy with non-healing ulcers on the cornea. Pathogenesis of different types of keratitis. Epithelial occurs due to active viral replication. Stroma can have viral replications plus immune-mediated reaction. Endothelial, again, viral replications with immune reaction. Neurotropic occurs because of the reduced corneal sensation. Here is a case of a deciform keratitis has due to stromal immune-mediated response. This patient responded well to topical steroids, cycloplegic agents, and systemic oral valacyclovir therapy, following which we could see the scar formation in the stroma. The next comes viral endothelitis can have associated uveitis, responds well to antiviral and topical steroid therapy. Neurotropic keratopathy occurs due to alterations in the corneal nerve leading to impairment in the sensory and tropic function with subsequent breakdown of the corneal epithelium. Even if epithelium heals, they form recurrent erosions, corneal epithelial defect, ulceration. In severe cases can have perforation if it's not covered under appropriate antiviral therapy. What are the challenges we face in ocular herpetic disease? The unmet needs. Sometimes they are steroid dependent. As long as you put them on topical steroids, they are doing fine. The minute you start tapering, they show the recurrence. If you use it on long term, they can develop antiviral resistance. In chronic cases, they can develop corneal neovascularization on the ocular surface. The major challenge is recurrence of herpetic eye manifestations. The next comes viral anterior uveitis. The diffuse pigment keratic precipitates or pigments on the corneal endothelium is one of the characteristic features of viral anterior uveitis. They can have reduced corneal sensation, responds well to topical steroids and cycloplegic agents with plus or minus antiviral depending upon the etiology. They are characterized by the presence of pigmented keratic precipitates, diffuse fine keratic precipitates, atrophic patches on the iris. Whenever we see this kind of morphology, we need to suspect viral anterior uveitis. The recent Sun working group has classified the various uveitic entities. In this, key criteria for HSV anterior uveitis is positive PCR assay for the HSV virus, can have sectoral or diffuse atrophic patches in a patient less than 15 years of age, can have associated HSV keratitis. In this, we diagnose HSV anterior uveitis. Key criteria for varicella zoster virus anterior uveitis as per the Sun working group, it shows positive aqueous humor PCR for the varicella zoster virus, can have sectoral iris atrophy in a patient more than 60 years of age, can have concurrent or recurrent dermatomal herpes zoster lesions. Based on this, we make the diagnosis. Coming to the CMV anterior uveitis, it can occur in immunocompetent individuals. Unilateral anterior uveitis with positive aqueous humor for PCR assay for the CMV virus. No clinical features reliably diagnosed CMV anterior uveitis. However, they can have central white keratic precipitates, coin-shaped keratic precipitates. Here, the corneal sensation will be normal in case of CMV anterior uveitis. Here is a case of a CMV uveitis who had anterior chamber reactions and PCR came positive for the CMV, and confocal microscopy showed infiltrative as well as globular pattern of keratic precipitate. We did start the patient on topical cancyclovir gel and topical steroids. However, follow-up 1 week, they did not change in the morphology. The inflammation was persisting. We put the patient on oral valganciclovir. Subsequently, we could see the resolution of the keratic precipitate both on the clinical examination and also on the confocal microscopy. Confocal microscopy in viral uveitis shows infiltrative pattern of keratic precipitates. This we see it in viral, commonly in herpetic group of viruses. Whereas in CMV anterior uveitis, it shows classical howl-like pattern of keratic precipitate. In addition to endothelial changes, we can study the nerve fibers on confocal microscopy. Let's see how are we going to differentiate between these three types of viral anterior uveitis. HSV can have systemic infections associated with it have elevated intraocular pressure in a case of HSV and VZV. In CMV, also there is intraocular pressure is elevated. So one of the characteristic feature in viral uveitis can have associated IOP elevation. Corneal sensation, as I told, it's normal in CMV, whereas it is decreased in HSV and VZV. HSV can have associated dendritic ulcers. VZV has pseudodendritic ulcer. CMV, nodular endothelial lesions in acute cases, whereas endothelial lesions in chronic cases. The KPs can have small, white or pigmented keratic precipitates, whereas in acute CMV has granulomatous, whereas chronic CMV has fine, pigmented or stellate keratic precipitate. Iris atrophy, as patchy iris atrophy, could be diffuse in HSV, whereas in VZV we get sectoral iris atrophy. CMV also shows diffuse patchy iris atrophy. AC reaction is mild to moderate in most of the cases, whereas in VZV it can be severe. We'll move on to viral posterior uveitis. Here again, herpetic posterior uveitis are the commonest. It can occur both in immunocompetent as well as immunocompromised individuals. In immunocompetent, acute retinal necrosis is the commonest. We can get non-necrotizing herpetic retinitis. In the immunocompromised, we have progressive outer retinal necrosis, what we call it as PORN or CMV retinitis. CMV retinitis commonly occurs in immunocompromised. We can get in immunocompetent individuals. Here is a case of a 13-year-old girl presented with blurring of vision in both eyes. She gave history of fever for 10 days. There was fine KPs on the corneal endothelium. Fundus examination shows hyperemia of the disc with whitish infiltrates on both the eyes. FFA showed disc staining and perivascular leak. OCT shows vitritis with hyperreflectivity on the retinal layers. The similar findings were seen in the left eye too. We did the investigations. Basic workup was negative for causes for fever, and AC tap showed VZV, varicella zoster virus. We put the patient on systemic acyclovir and oral steroids. Subsequently, we could see the resolution of the inflammation. This is a case of a non-necrotizing herpetic retinopathy. Herpetic retinitis is caused by herpes group of viruses. It could be by the HSV or VZV. They have significant vitritis, as we see in this case, can have granular retinal lesions with retinal vasculitis without necrosis. This is a characteristic feature. Diagnosis by the PCR reaction from the ocular fluid, either from the aqueous or from the vitreous. We treat them with systemic antivirals such as acyclovir are effective, combined with corticosteroids. Next, we'll move on to necrotizing herpetic retinopathy. It is an emergency condition. When the patient presents with, we need to make the diagnosis based on the clinical presentation. Molecular diagnostics help us to confirm the diagnosis. Here is a case of acute retinal necrosis where you can see the peripheral whitening. It is called Swiss cheese pattern. Progressive outer retinal necrosis occurs in an immunocompromised individual. It is most often is bilateral. This has a cracked mud appearance. CMV retinitis occurs in immunocompromised individuals, can have pizza pie appearance or tomato ketchup appearance. Whenever we see, we need to make the diagnosis and start the antiviral at the earliest. Coming to ARN, it's an acute unilateral PAM uveitis with retinal periarteritis, progressing to diffuse necrotizing retinitis, can have retinal detachment as a complication. It's caused by varicella zoster virus, herpes simplex 1 and 2, and rarely EBV virus. Reasons and classification has removed CMV from the ARN cause. Some criteria for the ARN is a necrotizing retinitis involving the peripheral retina and evidence of infection with HSV or VZV and positive PCR for HSV or VZV from the aqueous or the vitreous specimen. This from the characteristic clinical feature of circumferential confluent retinitis involving the retinal periphery, associated vascular sheeting and occlusion of the vessels, and more than minimal vitritis. We need to rule out other associated systemic infections like syphilis and toxoplasma and CMV infection. Whenever we see a clinical suspicion of ARN, we start them on empirical antiviral therapy. If the facilities are available, you can do the molecular diagnostic test to confirm the exact etiology. We also have to work up this patient for systemic parameters because we need to put them on long-term antiviral, and also we have to start them on systemic steroids. As we mentioned in the SUN criteria, we have to rule out other associated systemic infections. Coming to treatment algorithm, the induction treatment includes intravenous acyclovir or oral valaciclovir. Both are found to be equally effective. If it comes to intravenous acyclovir, we give 10 mg per kg 3 times a day for 7 to 10 days, followed by oral valaciclovir 1000 to 2000 mg 3 times a day. Can be combined with intravitreal ganciclovir or foscarnate. Topical steroid cycloplegic agents. If the IOP is elevated, we also had topical anti-glaucoma medication. After 48 hours, we do start this patient on oral steroid therapy. Following the induction of 2 weeks, then we can switch. This patient needs to be treated for longer duration. Basically, for ARN, we put them on oral valaciclovir 3 times a day for 12 to 14 days. If the patient had associated systemic complications, we do put them on long-term maintenance therapy. The important is, even if the lesion's retinitis is heals, you have to continue this antiviral therapy for a longer period of time, at least for 14 weeks, to prevent the other eye involvement. Management includes systemic corticosteroids. Intravitreal corticosteroid is controversial. Antiplatelet therapy and prophylactic panretinal photocoagulation as a controversial role. Here is a 17-year-old man presented with redness and reduced vision in the right eye for 1 week. 10 days prior to the presentations, he has received first dose of COVID-19 vaccine during the pandemic. His best corrected visual acuity was counting finger 1 meter. Here you could see the diffuse fine keratic precipitates. Confocal microscopy showed infiltrated pattern of keratic precipitate suggestive of infective etiology. Fundus examination, we could see focal, well-demarcated retinal necrosis in the peripheral retina with circumferential progression with associated occlusive vasculopathy was seen. On OCT, we could see the significant vitritis with full thickness retinal involvement. Following the treatment with antiviral and systemic steroids, we could see the resolution of the inflammation with few fine pigments. However, the confocal showed infiltrative pattern was disappeared. The fundus shows healed retinitis lesion. OCT shows thinning of the retinal layer. So it's important that we need to follow up these patients. They can develop retinal break and retinal detachment even in the inactive phase. Next comes progressive outer retinal necrosis. It is a nightmare for the treating ophthalmologist. It occurs in immunodeficient individuals. It has relentless progression in spite of starting this patient on antiviral therapy. When you see in OCT, you could see the outer retinal involvement. Within few days, you could see the necrosis of the retina and thinned out retina. Invariably, they end up developing retinal detachment. Here, the surgical management with silicone oil can restore the anatomical. However, the functional outcome is not very satisfactory in this patient. So, it's a fulgurant necrotizing retinitis, starts in the posterior pole. It's rapidly progressive. Most of the times, it is resistant to antiviral therapy. Herpes, in addition to the retinitis, it can also cause orangish or yellowish lesions with indistinct borders situated deeply in the choroid. It occurs due to decreased melanin in the choroid melanocyte due to VZV infection, which we described it as viral keratouveitis with choroidal vitiligo-like lesions. They develop once the acute HZO resolves. Few months later, they manifest with these changes. Next comes cytomegalovirus retinitis. They have classical pizza pie appearance or granular form of retinitis or frosted branch angiitis. Here again, we need to rule out retroviral infection and start this patient on systemic antiviral therapy along with ART. This will be covered by the subsequent speaker. These are the various drugs is used in the treatment of CMV retinitis. It is available both in the form of systemic as well as intraocular use, where we have ganciclovir foscarnate is available for the intraocular use. Next, we will move on to the measles. The measles, the causative organism is an RNA virus. RNA viruses are very fragile. Infectious period from 5 days prior to the rash until 4 days after the rash appears. Coming to the mode of transmission, by aerosol entering into the respiratory mucosa or by the conjunctiva. The incubation period is 6 to 21 days. Coming to the systemic features, they can have fever, malaise, cough. They can have buccal mucosa. The scoplic spots is a characteristic finding to diagnose measles infection. The exanthem develops 2 to 4 days into the febrile syndrome. Classically begin on the face and then spread downward towards the rest of the body. Typically spares the palms and soles. Their erythematous, maculopapular and blanching lesions can have associated lymphadenopathy, respiratory symptoms and pharyngitis. Systemic symptoms can have associated complications like diarrhea, neurological syndromes like acute disseminated encephalitis. SSPE is the severe complications, that is subacute sclerosing panencephalitis following measles, can have superadded bacterial infections and pneumonia. Ocular features, they can have conjunctivitis, mild and non-purulent discharge with conjunctival papillae, coplic spots on the conjunctiva. They are called Ishbak spots. Epithelial keratitis starts in the limbus, progress centrally, does not involve the Bowman's layer. They resolve without scarring. Stimson's line is sharply demarcated, transverse line of injections along the eyelid margin. Coming to the ocular features, they can cause acute retinitis or even subacute sclerosing panencephalitis, necrotizing retinitis, chorioretinitis with venous tartuosity, retinal hemorrhages, and subretinal exudates. We diagnose based on the positive serological IgM titer, detectable 3 days following the appearance of exanthem, and it remains present for about 30 days. Seroconversion can occur from negative to positive serum IgG. Fourfold increase in the titer of IgG over 4 weeks can occur. Can have rarely the culture, which is very rare, and PCR also can be done from the nasopharyngeal secretions. There is no specific antiviral therapies available for the measles. Vitamin A supportive therapy, and we need to treat complications. Topical supportive therapy is used for the ocular findings like antibiotics to prevent the secondary bacterial involvement and anti-inflammatory corticosteroid drops. The next comes mumps. Mumps is an RNA virus of paramyxovirus family with human as a natural host. Coming to the systemic features, history of fever, parotitis, salivary gland swelling prior to the ocular presentation. They can have CNS manifestations like aseptic meningitis, encephalitis, rarely sensory neural deafness. The reproductive tract can also be affected with architis or ophiritis. Cardiac sequelae can occur, may include myocarditis, pancreatitis, and other nephritis. Coming to the ophthalmic manifestations, they can start with pole-to-pole, conjunctivitis, dacryoadenitis, endothelitis, as seen in this photograph, an anterior uveitis or keratouveitis, can have hypertensive anterior uveitis. In the eye, they can have optic neuritis, neuroretinitis, or multifocal retinitis. A characteristic cerebriform pattern of retinitis is one of the clinical clue to diagnose mumps virus retinitis. Rarely, MMR vaccine-associated uveitis also can present with mumps virus uveitis. We diagnose based on the positive serology IgM and IgG antibodies. We have to treat symptomatic with supportive treatment. If the eye involvement is there, especially the necrotizing retinitis, we can treat them with intravenous methylprednisolone followed by oral steroids, intravenous immunoglobulin for CNS manifestations, or intravenous interferon alpha, plasma paresis, or hyperbaric oxygen can be given if there is an ocular involvement. Prevention with live attenuated mumps vaccine administered in combination with MMR vaccine is recommended, with the first dose is usually given at 12 to 15 months of age. The second dose can be given anytime between 13 months to 13 years. So it is important that we recognize the mumps based on the characteristic presentation, can have associated parotid involvement, and when we probe the history, the similar epidemic will be going on in the neighborhood. Next, we'll move on to post-fever retinitis. Here, the patients would have had fever many weeks before the presentation. They may not associate with the history of fever. We have to probe them. This post-fever retinitis can have 2 weeks to 6 weeks after the fever episode. It can be caused by various viruses like Chikungunya, Dengue, West Nile, Ebola, and Zika. Rarely, recently, SARS-CoV-2 has been added in the list. Coming to the diagnosis, we make post-fever retinitis based on the clinical diagnosis. Molecular diagnostics such as nested PCR help us to confirm the herpetic group of viruses. RT-PCR help us to confirm the RNA viruses. If we do not know what virus it is, if we have the facility, we can subject the specimen for next generation sequencing to find out the novel virus. We can also diagnose these entities by serological antibody titers of both IgM and IgG antibodies. Can have Goldman-Whitmer coefficient more than 3 diagnostic of infection. In the early period, in the acute, we do make the diagnosis based on the PCR. In the later part of the disease, the Goldman-Whitmer coefficient or the presence of antibodies help us to make the diagnosis. Here, algorithm for the suspected case of viral retinitis. First, whenever we have a viral retinitis, they can have associated systemic symptoms like fever, skin rash, and joint pain. We need to rule out associated systemic disease, SLE, HIV, syphilis, and toxoplasma. If it's sporadic, it could be ARN, PVOR, and CMV. We make the diagnosis with molecular diagnostics and treat them with appropriate antiviral therapy, which we have seen in detail. Next comes epidemic retinitis or post-fever retinitis can be caused by chikungunya, dengue, West Nile, or rickettsia, rarely bacterial infection also can cause. Then here you do the serological documentation for chikungunya, dengue, and West Nile. Symptomatic management, doxycycline proved to have effective against dengue virus. It can be given doxy with oral steroids. The next comes the novel Zika, Ebola, and H1N1 have been reported with posterior segment manifestations. Recently, COVID pandemic caused by the SARS-CoV-2, we do treat them with systemic steroids and anticoagulant depending upon the phase of the disease. In the acute, we do treat them with antiviral. Most of the ocular presentations we see in the inflammatory phase of the disease. Coming to the management, antiviral therapy, which includes systemic and topical. We can give intravitreal injections, long-acting intraviral implant, and highly active antiretroviral therapy for HIV-associated infections. This is for general, which includes both DNA and RNA viruses. If the patient have developed complications like retinal detachment, we do manage them with surgical management with plasma vitrectomy with silicone line injections. Laser treatment is controversial. There is no role for prophylactic laser. The next comes, this is a busy slide showing the antiviral therapy which is used in the management of CMV retinitis. Intravitreal, we have ganciclovir, not only the injection and also the implant, both fascarnate and cidofovir is also available for intravitreal injections. Coming to complications, development of heartache can occur. In addition to vitrectomy, we can also do with silicone buccal and silicone oil tamponade depending upon the site of the involvement. If you state the patient on CMV retinitis with anti-CMV therapy, once the CD4 count improves, they can develop immune recovery uveitis, where we have to add additional steroids. Next is important, there is no role for prevention with antiviral therapy. The next comes the West Nile virus. It's enveloped a single-stranded RNA virus. It's caused by the Culex mosquito. High-grade fever, headache, and myalgia and arthralgia. Can have severe neurological disease like meningoencephalitis. Frequently, this West Nile occurs in advanced age with diabetic association. It causes multifocal chorioretinitis with typical fluorescent angiographic features along the nerve fiber layer, but it can involve without that particular pattern as well. As I told you earlier, diabetes mellitus appears to be the potential risk factor for the severe neurological disease and also the chorioretinitis. ELISA, serological antibodies, and PCR testing helpful to diagnose West Nile virus infection. There is no proven treatment, antiviral therapy for West Nile. Newer drugs like interferons and intravenous immunoglobulins can be tried. We treat symptomatically with topical steroids, oral steroids. If associated complications, we treat them appropriately. Next, we'll move on to dengue uveitis. Dengue is caused by the flavivirus. It is transmitted by the Aedes aegypti mosquito. In addition to fever, dengue infections can cause headache, myalgia, thrombocytopenia, resulting in bleeding manifestations such as purpuric rash. Hypertension may also occur in dengue shock syndrome, which carries high mortality. Systemic manifestations most of the times is mild self-limiting flu-like syndrome. Dengue hemorrhagic fever or dengue shock syndrome is a severe form, potentially fatal form of infections with plasma leakage, severe bleeding, respiratory distress, and can lead on to multi-organ failure. Infection with one serotype provides lifelong immunity against subsequent infection by the same serotype, but only partial immunity against infection with other serotypes. It is important. The next comes patients presents with headache, eye pain, muscle pain, rashes, nausea, vomiting, and joint pain, similar to any other infection. This is the busy slide showing the various ocular manifestations. This can have simple subconjunctival hemorrhage, scleritis or necrotizing scleritis or scleral melt, anterior uveitis, have intermediate panuveitis with retinochoroiditis, dengue foveolitis, or can have vascular occlusions, optic neuritis, and panophthalmitis. Coming to the posterior segment manifestations, scan varies from retinitis, foveolitis, dengue-induced inflammatory ischemic foveolitis, or outer maculopathy. Can have associated retinal and vitreous hemorrhages with vascular occlusions. Diagnosis of dengue fever based on the clinical presentation, and also we make the diagnosis based on the reverse transcriptase and IgM and IgG antibody. We do serum platelet measurements track to study the thrombocytopenic pattern if the patient presents during the acute stage of the disease. Management. Ocular manifestations of dengue infection can be self-limiting. However, immunosuppressions with topical, periocular, oral, and intravenous steroids have been used in the management of dengue infection. With ocular manifestations. Here is a case of a 40-year male presented with decreased vision, had fever with skin rashes, as low platelet count, dengue antibodies were positive. Here you could see the multifocal retinitis with grayish lesion in the fovea. The OCT shows foveolitis. So this is a dengue foveolitis. This patient was treated with systemic steroids, following which we could see the resolution of the retinitis and foveolitis. Next, we'll move on to chikungunya. It's a single-stranded RNA virus, belongs to the genus alpha virus in the family Togaviridae, transmitted by the Aedes mosquitoes. Ocular manifestations can present at the systemic illness or resolution of the systemic disease, can present with floaters, pain, and photophobia. Posterior segment manifestations includes retinitis, neuroretinitis, optic neuritis, rarely vascular occlusion. Be diagnosed by RT-PCR for chikungunya virus during the acute fever time, or if they present in the later part, IgM or IgG antibodies are useful to make the diagnosis. We manage this patient only with supportive therapy. Here is a case of a chikungunya retinitis, shows multifocal retinitis with retinal hemorrhages in both eyes. Yet another case of a chikungunya retinitis. Here, the patient presented history of fever with rashes 4 weeks before he was diagnosed to have 4 weeks before she was diagnosed of a chikungunya fever. Here you could see a retinitis, early hypo with late hyperfluorescence, hyperreflectivity with after shadowing. Following treatment with systemic steroids, you could see the resolution of the retinitis with thinning of the nerve fiber layer of the retina. Next, we'll move on to Ebola virus. It's hemorrhagic fever. It's a deadly disease caused by the Ebola virus. Causes conjunctival ingestion and uveitis. Here you could see the persistence of virus in the anterior chamber even after resolution or chorioretinal scars in the eye. Systemic disease characterized by fever, vomiting, diarrhea. Arthralgia, enthesitis, and uveitis can have associated thrombocytopenia and transaminitis. Transmission through the mucous membrane and body fluids. Favipiravir can be used. Monoclonal antibodies also have been tried in the management. Next, we'll move on to the Zika virus. It is a flavivirus transmitted by the Aedes mosquitoes. Microcephaly and presumed Zika virus intrauterine infections who had macular pigment mottling and loss of foveal reflex. The diagnosis by IgM and plaque reduction neutralizations and polymerase chain reaction testing. So this is a picture of a paramacular supratemporal round chorioretinal atrophy surrounded by hyperpigmented halo and hyperpigmented mottling. So this is a characteristic clinical picture of congenital Zika infection. Congenital infection is due to presumed Zika virus exposure was associated with vision-threatening findings. Majority of the cases had bilateral macular or perimacular lesions as well as optic nerve abnormalities. Here is an autofluorescence showing both hypo as well as hyperautofluorescence. FFA shows disc staining and perivascular staining in a case of a Zika uveitis. Next, we'll move on to COVID. It's caused by the SARS-CoV-2 virus. Recently, we had a pandemic. In that, we had varied manifestations, starts from conjunctivitis to keratitis, episcleritis, scleritis to uveitis. We also had panuveitis and endophthalmitis cases. Many had vascular occlusions. In addition to CRVO and BRVO, we had microvascular occlusions like AMN and PAM, that is paracentral acute middle maculopathy, just diagnosed with the help of the OCT, and cotton wool spots in the fundus. In the second wave, when the patients were treated with high dose of steroids, they developed diabetes and mucormycosis was seen. They present with uveitis and vascular occlusion. So these are the various manifestations come from anterior uveitis to SARS-CoV-2 retinitis. Whenever we see a patient with SARS-CoV-19 with uveitis, we need to differentiate what stage of the disease are we seeing. If it is infective, diagnosed by RT-PCR, and we treat this patient with antiviral therapy. If it is inflammatory and hypercoagulable, we treat them with corticosteroids and anticoagulants. If there is a secondary infection, we treat them with appropriate antimicrobial therapy with antibacterial or antifungal agents. Multi-inflammatory syndrome, MIC, in children have been associated with coronavirus. Clinical features is mimicking Kawasaki disease, can present bilateral uveitis, elevated COVID antibody titers were present. These kids were managed with intravenous immunoglobulin and oral steroids. We also have studied the systemic markers and ophthalmic manifestations of post-coronavirus disease of COVID-19, and we did notice increased serum D dimer and ferritin levels were statistically significant and were higher in patients with sight-threatening ocular manifestations of COVID-19 uveitis. Next, we'll move on to the last entity. I kept it as rubella. It's caused by the rubella virus as a toga virus. Infection period up to 10 days after the rash begins. Mode of transmission by respiratory droplets, vertical transmission from mother to fetus. Coming to the systemic features, acute onset of maculopapular rash begins on the face and spread downward toward the trunk and extremities. Low-grade fever can have associated lymphadenopathy like posterior cervical, auricular, and suboccipital nodes. Congenital rubella syndrome can have sensorineural hearing loss, CNS manifestations like microcephaly, calcifications, and meningoencephalitis, cardiovascular defects. Ocular defects can develop over the time after the birth, and early infection first trimester is associated with 80 to 85% risk of defects. Later infection is associated with much lower risk. Can have ocular features like bilateral salt and pepper presentation. Cataract can develop. Fuchs uveitic syndrome have been reported. Congenital glaucoma and secondary glaucoma also can occur. Other ocular features, keratopathy, strabismus, microphthalmia, and colobomas. Diagnosis by the serological IgM antibody for the rubella virus or congenital infection by PCR from the amniotic fluid or other products of conception. There is no specific antiviral treatment for rubella. Management includes supportive. Prevention by MMR vaccine is used to prevent congenital rubella syndrome. Complications can have CNS manifestations. Congenital rubella can cause miscarriage, stillbirth, birth defects, and asymptomatic infection. Here is a case of a 2.5 months old child born at 34 weeks with a birth weight of 2.25 kgs present to us in 2nd December 2013 for ROP screening. Visual acuity by telar acuity card was 38 centimeter by is 20 by 270 in both eyes. Anterior segment examination was within normal limits at the time of presentation. During the ROP screening, our team did notice there was a yellowish white retinal infiltrate in the mid periphery and the periphery. That time the patient was referred to us. On evaluation, we also noticed the child had hearing impairment and serological titer for both IgM and IgG was positive. Systemic evaluation child at PDA. On evaluation, the cardiac PDA was spontaneous closure was happened. For hearing impairment, we referred to the ENT person. Sensorineural hearing deafness was confirmed and child underwent cochlear implant surgery. The follow-up 1 month showing resolving retinitis in both eyes. The rubella titer has decreased from 1.78 to 0.54. This is the follow-up after 12 years. The child has visual acuity of 6.6 and 6.6 parts in both eyes, where we can see both hypo as well as hyperpigmented spots, what like classically described as salt and pepper retinopathy of congenital rubella syndrome. This is such thing the child had a cochlear implant and now he's doing well. He's going to the normal school. He's excelling in his studies. Autofluorescence of the same child now shows classical salt and pepper retinopathy on fundus. OCT shows normal foveal contour in both eyes. This child had a bilateral rubella retinitis. Congenital rubella infection was suspected based on the serology. We did work up the systemic case and associated systemic complications was tackled because of the hearing, cochlear implant and vigorous rehabilitation was done by the parents, both for the hearing and also for the speech, resulted in good outcome in this child. To conclude, clinical features of eye in systemic viral infection can present during the acute episode or in the later part of the disease. Many times, eye acts as a window to find out the systemic viral infections. We make the clinical diagnosis based on the characteristic morphological pattern. It's basically a pattern recognition, especially acute retinal necrosis and POR and progressive outer necrosis or ophthalmic emergency. We have to start the antiviral at the earliest without any delay. Investigations to find out the systemic infections either by the molecular diagnostics from the ocular fluid or from the systemic specimens. If they present in the later part of the disease, serological antibodies help us to make the diagnosis. We need to put them on appropriate antiviral therapy if it is available, like DNA and herpetic group of viruses. If like RNA and arbo group of viruses, if there is no antiviral, we have to manage them with supportive therapy and control the inflammation. The most important is prophylaxis. Especially for most of the viruses, we have like MMR vaccine and herpes zoster vaccine. The vaccines are available. We need to give this to prevent the sequelae. I'd like to acknowledge my team members for the contribution. Thank you for your attention.
Thank you, ma'am. Thank you for that very informative and well-articulated class. That really was a great umbrella under which all of the viral infections were included. And most of your slides were put in the form of long answer questions, which is really going to help postgraduates. I mean, that can be taken as it is, and it's really good to memorize as well as just put it down in the answers as well. We have a few questions, ma'am. Some very basic ones beginning from history itself. What are some important points to be asked in history if we are suspecting a viral etiology for retinitis? I think we all stumble after a point once we ask about a history of fever or a cough or cold. Is there anything more specific we can ask for viral etiologies?
Skin rashes plays a major role, and especially if there were skin lesions. Herpes zoster, that could be the clinical clue. When the examination also will pick it up on the scars which is present on the forehead. And most of the arboviral, other viral infections can have petechial rashes. Many times these patients may not correlate with that. I feel the skin lesions and also fever, joint pain helps.
Okay, ma'am. Okay, ma'am, what is the specificity and sensitivity? I mean, how useful is PCR in diagnosing viral retinitis from an aqueous or a vitreous tab?
Definitely, the sensitivity is much higher with PCR. With sensitivity is more with vitreous compared to the aqueous. But as you know, when the patient has necrotizing retinitis, we can't subject them for a vitrectomy because the necrotic retina will lead to complications. Most of the times, these patients they have spillover inflammation into the anterior segment. So aqueous PCR works well in detecting these entities.
All
If they
right, ma'am.
present in the later part, then we go for the antibody testing. But for
Okay.
viral, definitely PCR plays a role.
Okay, so ma'am, by later, after what duration of symptoms or in what point of time in the history can we go for the antibodies?
It depends on when we ask the patients from the eye presentation to the history of fever. If it occurs within few days during the infective phase, if the patient presents with ocular manifestations, then PCR is going to play important role. Or in other conditions, if the patient is immunocompromised with compromised renal function where you have to put them on antiviral, there the molecular diagnostics plays an important role based on the not only the diagnosis, but we can do rt-pcr with the quantification of the organisms which help us to titrate the treatment. If they present in later part of the disease, then we go for antibody testing.
All
Or
right.
in some RNA viruses where the PCR is not freely available, or because they are very fragile, they have to transport the specimen in a dry ice pack, and with strict rules have to be followed. If it is not available at many centers, then we go for the antibody testing. Especially for a post-fever retinitis cases, we diagnose based on the serological antibodies.
All right, ma'am. Thank you. Okay. Ma'am, if a neonate with suspected torch infection has chorioretinitis, does it differ from the adult presentation?
See, basically, when the neonate, you need to check what kind of a pattern they have. Even if they have a torch, each disease has. When you're having a neonate, we need to ask the mother's history. What kind of, whether mother had maternal illness, if she had what period, first trimester, second trimester, or third trimester, what kind of a lesions, that itself will give us a clue what she had. And the second thing is we have to see morphology. If you have a punched out scars in the bilateral lesions, then it goes more towards of toxoplasmosis that all of us will make based on the clinical presentation. If you have a salt and pepper retinopathy, it goes towards the rubella. Whereas the other herpetic and CMV, they have retinitis where the molecular testing help us to diagnose. In children, they may not get the fitness for a procedure to undertake and the AC is shallow. So in that situations, you can do the PCR from the serum, from the blood that help you to give, because most of the times this have associated systemic infections that help us to make the systemic diagnosis.
Okay. And ma'am, is the presentation different in an adult than a neonate, the ocular presentation?
See, basically what happens is if you say in a neonate, it's obviously a congenital toxoplasmosis. Whereas in adult, they can have acquired toxoplasmosis where they present only with retinitis or without a scar. That is in case of toxoplasma. Coming to rubella, this child had active retinitis as shown in this photograph, and the child developed scarring over the period of time. So in a neonate, when you see a congenital rubella, you can have a retinitis or they can get into scarring where the salt and pepper retinopathy can be evolving. In adult, you do get the fully formed retinopathy, salt and pepper retinopathy.
Okay. Ma'am, is there a minimum quantity that should be taken for an AC or vitreous tab for investigation when we are
For
drawing the sample?
PCR, we just take about 0.1 ml, 100 microliter are sufficient, but the recent advances, some they do even 50 microliter, but we recommend to take 100 microliter. 0.1 ml is sufficient to get the PCR, and now we have a multiplex PCR with same 0.1 ml, we can get multiple ones.
Okay, all right. Ma'am, what systemic evaluations are indicated when a viral etiology is suspected?
It depends upon the what kind of a viral infections you have. Viral, when they present with acute, they'll have fever, cough, cold. Sometimes can have associated systemic involvement like lymph node enlargement. Can some infections like hepatomegaly, splenomegaly can have with the liver dysfunction or the liver enzymes abnormality. So these are the things we can have, especially when you have a dengue, you have to watch out for the platelet count. And many times they end up giving the blood transfusion, which is not warranted. So it causes immunological reaction and it exacerbates the inflammatory response and they develop panophthalmitis like kind of a picture.
All right. Ma'am, are there any specific fundus autofluorescence or OCT features which can distinguish viral retinitis from other causes of necrotizing retinitis?
Yes, when you do a OCT, which help us to differentiate whether it is retinitis or retinochoroiditis. So, necrotizing retinitis, the commonest cause everywhere is toxo. Whereas toxo and viral can get confused, but you can make the diagnosis. And toxo, you can have a scar or a satellitic lesions, can have significant vitritis. When you do an OCT, it causes both full thickness retinitis with choroidal involvement. In viral, where you have herpetic full thickness involvement, PORN I showed full thickness involvement. Even though they say the choroid is not common, we have seen and also we have reported herpes can involve choroid as well. That one.
Okay.
And if you have a dengue, you can have classical foveolitis, what we saw in a photograph. And any kind of a posterior retinitis, they cause hyperreflectivity in the inner retinal layer with after shadowing. So there is no full thickness involvement. You can differentiate posterior retinitis with necrotizing retinitis based on the OCT morphology.
Okay. All right. All right, ma'am. Ma'am, how can we differentiate viral uveitis from autoimmune or bacterial etiologies based on clinical findings?
Viral uveitis, the patients will anterior segment involvement as is shown in the photograph. You will have a AC reaction. The keratic precipitates is very characteristic where you have diffuse fine stellate or pigmented keratic precipitates or pigmented keratic precipitate and can have associated iris changes. It could be diffuse patchy or atrophic patches on the iris, decreased corneal sensation in herpetic group of irises, associated increase in intraocular pressure. All this can, and when you put them on steroids, the pressures won't come down. The minute you put antiviral, the response is dramatic. Whereas in CMV, they will have a central coin shape, keratic precipitates. AC reaction may not be much. They can have increase in intraocular pressure. So
All
based
right,
on
ma'am.
that, you can differentiate.
Okay. All right. Thank you so much, ma'am, for answering all
Can
the
I make one
questions.
more comment?
Sure, ma'am,
So, yeah,
please.
whenever this part of the lecture, I would like to put it under three categories. So, whenever you get theory questions, you can have systemic viral infections with ocular features, or any other entity can come as a 10-mark questions. You go about first, you need to know what is the virus, which group does it belongs to. Second, what are the systemic features? If you have an incubation period to systemic features, you can mention. The next comes the ocular features. When whatever the characteristic finding of that particular virus you need to mention, we make the diagnosis. Definitely the molecular diagnostics and serological titers plays a role. Coming to the management, appropriate antiviral or anti-inflammatory therapy. These 5 points will be applicable to most of the viruses, which you can answer in that way. And the second thing is you need to make the diagnosis based on the pattern recognition. So once you know the classically described pattern of anterior segment changes or fundus photographic changes, you make the diagnosis. The third part involves after making it how you useful in your practice. One thing I would like to tell, whenever you're suspecting a viral, don't be in a hurry to start the steroids. We can have catastrophic changes, especially necrotizing retinitis needs antiviral. Under antiviral cover only, we can start them on systemic steroids. All the best.
That was a great tip, ma'am, for all exam going postgraduates. I think how to formulate a good answer is just as important as knowing what to really put in the answer. So that's a great exam tip. We'll end the session with the next session being on 9th of July on the topic of eye and HIV by Dr. S. Sudarshan. We'll see all our viewers back here then. And before we leave, just one last announcement. One second. Is my screen visible?
Yes.
Yeah. To all our viewers, the Physical Eye Focus 2025, that is the country's biggest national postgraduate education program in ophthalmology, is scheduled on from August 10 to 17 in New Delhi this year. You really don't want to miss this. Please grab your seats. There are very few of them left. You want to be there to listen to all the stalwarts talking about their subject specialties, and this is also a great platform for you to see what is there in the different subspecialties in the subject after your postgraduate or even during your postgraduate, because believe me, there's so much more to know beyond our post graduation. So you really don't want to miss this. Thank you so much, ma'am. We'll take a leave with this.
Thank you so much. Thank you.